Right. Good evening, everybody, and welcome to this Community and External Scrutiny Committee. I'm welcoming you to the very first meeting of the South Ribble Borough Council's Community and External Scrutiny Committee. I'm Councillor Ange Turner. I'm chair of the committee, and we'll do the introductions in a moment. I'm really pleased that this committee has been formed with the purpose of working with partners and others to improve the quality of life of local people and acting as the eyes and ears of our residents in South Ribble. We have committee members in the Civic Centre along with officers' support. The meeting is being live streamed via YouTube and will be available on the council's website. Some housekeeping for those in the Civic Centre. There's no fire drills planned, and if the alarm does go off, please leave by the emergency exits at the back of the room and congregate on the car park. Please turn off your mobile phones and switch your microphones off when not speaking, because if you don't do that, the camera will just home in on you when someone else is talking. For those joining us via Microsoft Teams, please remain muted and indicate at the appropriate time when you would like to speak, and I will bring you in. We are really grateful to our guests for attending this special health question time themed meeting. And if we can now do introductions of the committee members, and I'll start. So my name, as I've said, is Councillor Ange Turner. I'm a councillor for the Broadoak Ward in Penwitham of South Ribble Borough Council, and I'm also chair of this committee. Thank you.
I'm Councillor Matt Campbell, represent Walton Dale West Ward.
Hello, I'm Councillor Leslie Pritchard. I represent Lostock Hall.
Hello everyone, my name's Lou Jackson and I represent the ward of Earnshaw Bridge in Leyland.
Hi, I'm Councillor Keith Martin. I represent Middlefirth Ward. I'm also the lead member for climate change.
Evening members, I'm Dr. Sakthi Karunanidhi, Director of Public Health for Lancashire. Thank you.
Hello, my name is Gary Doherty and I am the Director of Strategy and Planning at Lancashire Teaching Hospital. Good evening.
Hi, I'm Sarah James. I'm the Integrated Place Lead for Central and West Lancashire and I work on behalf of the Integrated Care Board.
Evening, my name's Laura Walsh. I'm Director of Operations for Lancashire and South Cumbria Foundation Trust.
Evening, my name's Chris Oliver and I am Chief Executive at Lancashire and South Cumbria Foundation Trust.
Thank you, committee members and our special guests. I'd now like to move on to item 1 of the agenda, which is apologies for absence.
No apologies, Chair.
Thank you. Item 2, do we have any declarations of interest from committee members? Councillor Martin, please.
Thank you, Chair. It's a personal interest. I work for Lancashire County Council, and just to note that I'm on standby for gritting, and my phone's there just in case we do get dragged out. Hence my attire. Thank you.
Hello, I'd just like to say that I do sit on the Lancashire County Council Health and Adult Scrutiny Board.
Okay, I think we have...
Sorry, Councillor Turner. I've got a personal interest as a Lancashire County Council employee.
Thank you. I'd like to bring in Councillor Paul Wharton-Hardman, who's indicated to speak.
Thank you, Chair. I just want to declare an interest as a member of the Council of Governors at Lancashire Teaching Hospitals.
Thank you. Right, I'd now like to ask our special guests if they could just provide us each with a 3 to 4 minute overview of your organisation and your role in that organisation. And if you don't mind, could I start with Dr. Sakthi Karunanidhi? Thank you.
Thank you, Councillor Turner. So, as I introduced myself, I'm the Director of Public Health for Lancashire, but my employer is a County Council, the upper tier local authority, which is responsible for public health. The function moved from NHS into the councils in 2013. So this year is the 10th year since moving the public health functions from what was within the NHS into local government. The duties I have and the county council is responsible for is mirrored in the form of a statutory officer for public health. And largely speaking, you can summarize that as improving or taking necessary steps to improving and protecting the health of Lancashire residents, and to take steps to reduce health inequalities across the county. On a day-to-day basis, I'm responsible for protecting health of the public, which includes understanding the risks of the environment, risks from the environment, the chemicals, the biological agents, radiological, nuclear agents, and working in partnership with other agencies in preparing for emergencies and responding to that. The second part of my responsibilities include commissioning health improvement services, which ranges from tobacco, sexual health, combating drugs and alcohol, and indeed health visitors and school nurses. So it's across the age, across the life course, but more focused on prevention. And the third part of my role is working with, again, other parts of the organization and with partners in improving the conditions in which people live, work, visit. And by that, I mean natural and built environment, as well as wider policies that affect the health and well-being, which I hope we'll be able to cover this evening. So that's broadly my duties, and that is mirrored in the county council's responsibilities that concern public health. Thank you.
Thank you very much for that. Gary, would you like to just give us a quick overview? Thank you.
Yeah, thank you. So I work for Lancashire Teaching Hospital. So we provide a range of health services to the population. We provide specialist services for the whole of Lancs and South Cumbria for areas such as cancer, renal, major trauma, plastics and burns, and a range of other specialist services. So the population, if you like, would come to us for that, although we do have satellite services in a number of parts of the patch. We then provide what we'd call kind of local services for our kind of host population, and that would be things like A&E services and orthopaedic services, and those services that are provided by kind of all the hospitals in Lancs and South Cumbria. So we are a larger organisation. We employ just under 9,000 staff. We've got around 900 beds, mainly on our two key sites, which is Chorley and Preston, but we do provide services, as I've said, from a number of areas around the patch. And clearly, you know, as I say, we're a very busy organisation that I'm proud to work for. And thank you for the opportunity to come tonight.
Thank you. So I work on behalf of the Integrated Care Board, and this is a statutory organisation newly formed in July last year that came out of the recent changes to the NHS formed out of the existing CCGs. So the Integrated Care Board is responsible for meeting the health needs of the whole population, working with our providers and for managing the NHS budget. Obviously, it covers a huge area across Lancashire and South Cumbria, and that's why there are those of us here that work at place level. So for us, within Lancashire and South Cumbria, we have 4 places: Blackpool, Blackburn with Darwen, Lancashire and South Cumbria. I work within the Lancashire Place, and because of the size and scale of Lancashire Place, which covers the 12 district councils, we've separated ourselves to work within what we call localities. So I cover the areas of Chorley and South Ribble, Preston and West Lancashire as well. And part of my role as a place lead here is to help bring NHS organisations and other partners, including our district councils and our county council together, to look at how we can both help to integrate some of our services, but also how we can help to meet some of those health inequalities that previous colleagues have talked about. Just briefly, in terms of some of the functions that we have within our kind of local patch, my main area of work here is within the Chorley and South Ribble partnership that we've agreed will become the host partnership for some of the work that we need to do together. We very much wanted to build on some existing partnership arrangements rather than come and create, as sometimes the NHS does, is come and create new ones. We wanted to work with existing ones. So I do that as well as working with colleagues across the board to look at community services and how we can transform those across Chorley, South Ribble and Preston.
Thank you. So I'm Director of Operations for Central and West locality for Lancashire and South Cumbria Foundation Trust. Responsible for the delivery of adult and older adult mental health services, both community and inpatient services, as well as community physical health services for district nurses, community specialist nurses, treatment rooms, phlebotomy services. So I'm one of 5 network directors within the trust, and Central and West we have around 2,000 staff that work across the patch, and I work with a medical director and a nursing director to deliver those services across Central and West. Thank you.
Hello, so my name's Chris Oliver and I'm Chief Executive of the Trust. I've been with the organisation for 3 years and as Chief Executive since last October. I'm also a partner member on the Integrated Care Board for Lancashire and South Cumbria. So Lancashire and South Cumbria Foundation Trust is a mental health, learning disability, autism and community provider. It is the 6th biggest mental health provider within the country. We have a turnover of just over £500 million. 8,000 colleagues work to deliver our services across 800 beds, and we cover the whole span of Lancashire and South Cumbria, so from Colne all the way up to Barrow. As Laura said, we've split out into networks, so we've got 5 networks that provide our services, 4 based around geography, so Pennine, the Bay, Fylde and Central and West, where we are tonight. We've also got a specialist network and that manages all our children and young people services, learning disability, autism, as well as forensic services.
Right, thank you very much, visitors, for giving us an overview. We now have some questions we'd like to ask you, if you could answer them. I think some of the questions you may have to decide between yourselves who's best to answer that. You have to look at each other and say, is that you or is that us? Okay, so as is the custom and tradition of the chair of such committees, I'll ask the first question. Okay, you've got nothing to worry about. Okay, so thank you for your helpful overview of your roles, which shows how complex the health landscape is. How do you work together to make sure opportunities are seized, health is coordinated, and we provide a holistic approach to residents? Thank you.
We'll get better at the slightly awkward which one of us should start thing as we go along, I'm sure. If I just give a bit of a kind of general overview, and I'm sure my colleagues will jump in. So in terms of the question, which is obviously how do we work together? I think the recent changes within the NHS landscape has really enabled us to do that. So, for example, if we were to look at some of our community health services, which can include things like district nursing, some of our phlebotomy, which are blood testing, some of those services that we provide out in the community, we've now brought partners together to have a real good understanding of what some of the challenges are, how can we work together, and we have a clear work programme that sits across us as a number of organisations, and very much with a culture of what can we do to support those improvements rather than how can we hold each other to account for delivering some of those. And I'm sure Laura can talk in some detail about some of the work that we do in that board and probably Care Connections as well. Yeah. And then the other thing I was going to mention is, as well as that, we have a number of pieces of work where we're really trying to integrate services at a much more local level. So you may have heard about something called integrated neighbourhood teams, which is where we want to enable our residents who access services either through primary care, social care, community mental health or other providers, that those services can talk to each other, can support those patients to get access to a multidisciplinary approach to all the things that they may need support with. And we're really keen on connecting that with our district council colleagues as well, social prescribing, some of the other wider voluntary community face sector things. So there's just a couple of examples where we're either at a really local level, we're trying to work together within neighbourhoods, or then kind of at a slightly higher level to look at some of the big services and how we can bring those together.
Yeah. Thank you. So to build on what Sarah's explained, and I think probably to give a practical example of how we're working together, because I think we can probably talk about how we work together, but what does that actually mean? So I'll use an example for physical health. We're working with LTH, the Acute Trust, in how we can provide care for people at home and avoid going to hospital. We know that going to hospital can mean long lengths of stay, difficult getting home, a longer recovery period. So we've started a big transformation piece of work with the same-day emergency care team at the hospital and our community 2-hour urgent response teams. And both of those teams will see and treat people quickly and get them home as quickly as possible with the support that they need. What we've done is we've brought these teams together, and it's the start of a much bigger piece of work to have one front door for physical health services for central Lancashire. So one phone number that you can ring and get into the right service without you've rung the wrong number, ring this number, or I'm going to refer you, because we know listening to people, they don't want to tell the story 10 times. So Care Connections has evolved over the past 6 months, really exciting. So we've got same day emergency care at the hospital working with the 2-hour urgent response. We've already seen a reduction in the number of people being taken to A&E by North West Ambulance Service, so much so that they've now put a member of North West Ambulance in the team to take calls directly from 999 that are going through that acute route. And we've now got plans to build on that and bring more services in, the frailty service, working much more closely with virtual wards. So that's a very new initiative in Central, exciting. We've already seen the benefits of that, and we want to build on that. From a mental health perspective, we've got the community mental health transformation, which is a national agenda to provide a much more holistic mental health offer. And I think historically, you either met a threshold to go into services or then you were left with only a few options. This is to look at what does the population need and bringing not just health together, but local authorities, the voluntary sector, charities, in how we can offer alternatives. So loneliness, tackling loneliness. If we don't tackle loneliness, people get ill. They end up coming into statutory services. They end up becoming really unwell. And actually, we need to stop that. So the community mental health transformation is a national scheme, as I've said, but Central and West has been the first in our trust to go live with this model. So we went live in October, bringing local authorities around the table with health, with the voluntary sector, and we've got some ICB colleagues supporting as well. So those hubs have developed where the referrals go in and everybody's talking about, actually, I can offer that for that person. So we're not looking at, is it a health need? It definitely goes there. We're sort of pulling people into the services we think are best for them at that time. So really early days and lots to go on. This is phase 1. We've got another phase to come where we start building more additional enhanced support into the teams, and working with the ICB to commission the voluntary faith sector to provide an additional enhanced option into those services as well. So we're working with them and with LCC to commission what is needed for the population. And I think that's really important. We're looking at our data, the sorts of people that are accessing our services, rather than a one size fits all across Lancashire and South Cumbria. So they're just 2 examples of how we're working together.
Brilliant. Thank you. Thanks for that. We have a second question. Councillor Martin, please. Thank you.
Thank you, Chair. Thanks for coming. It's good to see you all. We're sort of conscious that you have quite a large geographical area, and obviously we're a small part of it. So I think the question would be, how would you sort of bring down your services to our levels at a district level, but also we have issues within that district level of health inequalities and things like that. So like a mile down the road, people die younger or older, depending on where you are. So how do you boil down your services to make sure these very small, tight communities get the help and the health advice and procedures that they need? That's for any of you.
So I think that's a great question. And I think particularly given, I would say, my organisation, the whole of Lancashire and South Cumbria. And in my kind of brief introduction, I talked a bit about place and the importance of place. And I think that's probably where we are spending an awful lot of time say, actually, if we were to make decisions on some of these things on a completely pan-Lancashire, never mind pan-Lancashire and South Cumbria level, we're not going to understand those nuances of some of the issues in particular wards or down to particular streets. So for me, that's where our place arrangements are really important. So I mentioned earlier on that we have across Lancashire, we split ourselves into 3 localities. And in those 3 localities, what we've done is said, let's have the same building blocks. we don't necessarily need the same consistency of arrangements, because as I said earlier on, we wanted to build on what was there, but let's have the same building blocks. So for us, those building blocks, they're developing these integrated neighbourhood teams, which are around much smaller populations, so kind of 30 to 40,000 populations generally, and they will use the data about the people who live in that area to think, actually, where do we might have a high correlation of cardiovascular disease, for example. How can we do more health checks with our population, working with different partners to target some of those things, kind of taking a bit of a population health management approach to some of those. So we have those integrated neighbourhood teams that will be at a really local level. And then for us in Lancashire, we've built on them with our health and wellbeing partnerships, or as I said, here we have our Chorley and South Ribble partnership. And within there, we're looking at actually what are the themes across the districts, the two districts that we want to work on collaboratively together. So the Chorley and South Ribble partnership, we've chosen Best Start in Life, or the partnership have chosen Best Start in Life. Looking at some of the facts around school readiness across the two districts, it was something that people felt they could really have an impact upon. And all of our partners from around this table all come to us at the Chorley and South Ribble partnership, so across Lancashire County Council, the hospital and LSCFT, to work with us on those more local issues as well. So I suppose there are two of the ways in which we're starting to understand the needs of our local communities and start to tailor pieces of work around some of those as well.
Thank you. Would any of you have anything to add to that? Because it is quite a general question that I think, if I can say, may affect all of you. Sorry, I'll take Gary first and then Laura. Please, Gary.
Yeah, thank you. Well, I think in lots of ways, I guess, is the answer, because you have to do it that way. I mean, Sarah's picked up some of the sort of organisational ways we try to come together and some of the data that we use. What I would emphasise, I guess, is that on top of that, we've just got staff out there every day listening to people and bringing back what they find. And obviously, for us as a hospital, we have a number of ways that we try and get feedback from people of what's working and what works well in one area doesn't work well or as well in another area. And obviously, then we have some people who are particularly motivated around certain conditions who would work with us around diabetes and some of the other ones. Sometimes people who've got a lot of experience of services, or maybe their family do, and obviously sometimes those are really positive and sometimes they're not positive. So whether it's patient stories at our board meetings, whether it's trying to drill down into the data, and I'd have to say I think that I've worked in hospitals for something like 30 years, and there's so much data in a hospital about what we do and how we do it. But I do think that in recent years we've got much better in a hospital like mine that does the sorts of things we do. Because what we used to do was count the number of operations and waiting times, and I think counting people's experience, but also trying to drill it down into and understand variation as to why it's working in one area, not in another. I think we are better at that, but I think both of the questions so far sort of speak to an agenda of how all these different health organisations that do kind of complicated things try and work together to get it right, but then also how they kind of listen to people. So as well as listening to each other, and I was going to come in on the last question, but I thought we kind of move on. I think each organisation has a really important role to play, but it needs to listen to each other and it needs to listen to the people in terms of what's working, and sometimes then that'll be something about my organisation, but that might be something that I need to feed back to Chris's organisation. And that's, I think, the way we try to kind of do it and get down to, as I say, fundamentally, what works well and what doesn't. And at any point in time, there's a lot that does, and there's an awful lot that doesn't.
Right. Thank you, Gary. I'll take Laura next and then Dr. Sakthi. Thank you, Laura.
Thank you. Yeah, just building on what Gary said, I think it's always the challenge. So if I think about my network, it's Central and West. We've got a big population. We've got Greater Preston, Chorley, South Ribble, West Lancashire, all with very different challenges. How we've decided to work in the model that Sarah's described around health and wellbeing partnerships, we've got senior representation on those in those meetings, feeding back into the network where we're discussing, okay, what's coming out of Chorley and South Ribble, what's coming out of Preston, what do we need to do differently, what are the opportunities. So I think that's definitely strengthened over the past 12 months with the changes with place and how everything's been set up. And I think Care Connections, we had a winter planning event recently where we've been looking at what can we do over winter to keep people well at home, avoiding admissions if they don't need it. And we were able, just by doing some of that connection, Chorley and South Ribble Council were there and saying, well, we've got this offer, so we're joining that in with Care Connection. So when people are ringing up and they're from the area, we're linking in them with the district council and their offers as well. So I think it is challenging, but I think it's absolutely what we're doing on a daily basis.
Thank you. Just reflecting on the first and the second question together, I think it's important to understand when we're talking about health, we're not just talking about the clinical services that are there. In other words, to improve health, we need to improve a lot more things beyond the NHS. And that's the first sort of thing to consider when we are talking about health for local district or across the Lancashire or Lancashire and South Cumbria. And the partnership happens in a number of different geographical levels. Some of them that concerns the NHS related things. We've got a geography of Lancashire and South Cumbria as the Integrated Care Board. But then we also got local government led things, initiated things that really determine our health and well-being and address health inequalities. And for us, in our context, is the county council and the district council relationship. So we've got a number of different partners working in different ways. But to answer Councillor Martin's question about how does smaller geographies get picked and attended to, it comes down to relationships with officers as well as between members, and alignment of policies and decisions, really. And I have to say there is a really good history of working between partners, especially when it comes to prevention, public health, and increasingly social care, NHS, GP practices included in that as well. At the district level, we've got a number of examples that we can list, and I'll just use a couple of examples, particularly related to housing, for instance. Things that work well in some aspects of housing, especially in promoting affordable warm homes, vulnerable households, children living in deprived neighbourhoods, getting support. Family hubs is another example of how various agencies come together and make a difference. And they all inevitably have community voice necessarily embedded in that. Where we could be even more working closely together and better, I would pick, again, sticking with housing, thinking about what's happening with our population in 10, 20, 30 years. It's a huge increase in people who are about 70 and 80, and thinking about how we plan for places. We tend to think in advance about local plans, what's going to develop where, in which part of the borough. We've got to apply the same mentality for health. It can't be just devising services year by year. So how do we make, for instance, lifelong homes possible? How can we make our communities really interacting with each other and making the best use of the local amenities, including the green space, which we are really have plenty in Lancashire, including this borough. So you can pick any determinant, and there is a lot of interaction happening at a local level, particularly some of the things that we get involved in are inevitably at neighbourhood level. But there's more we could do in encouraging better partnerships.
Thank you for that. I'd now like to ask Councillor Coulton, question 3. Thank you.
The question I was going to ask has been touched on a number of times, but I will ask it anyway. Tell me, how do you engage with borough councils on health matters, and specifically with South Ribble? Is there any way that we as a council could help you in your quest for better health for our residents? Thank you.
Thank you, Councillor Coulton. There's a number of ways that members are already involved in it, and we can definitely get it even better. And just as an example, health and wellbeing partnerships is being used. That's a new, refreshed way of working together, especially in the new health and wellbeing architecture. Scrutiny is another example of how members can really get under the skin of certain service changes. I'm observing a lot more collaboration in the last, certainly since the pandemic, a lot more collaboration and shared understanding between councillors in the district councils and county council. And we also have a lot of double hatters, so members who are both borough councillors as well as county councillors. So there's a range of interaction already going on. We do have development sessions, training sessions put on local government responsibilities on health and well-being. That's widely available. If we used to do it very regularly before the pandemic, and we will be scheduling that more so for district councillors particularly. And we don't just stop at the district level. There's also parish and town councils, and we've got a network of town and parish councils which we regularly interact. And I think that's an area that could get even better, I suppose, because when we come to talk about health, we tend to talk about GP practices, mental health services, NHS. And the place where the councils, the borough councils and councillors can make even better impact is in shaping the environment, the housing conditions, the neighbourhoods, the green spaces, and indeed being the channels and platforms for the local community voice, which is what we are grateful for, because the communities ever so better than some of us, and I would say most of us do. So thank you. Thank you for asking that.
Sarah, you indicated to speak. Thank you.
Thank you. I just wanted to build on Zaki's point with a couple of specific examples where I think we've got connections in place at the moment, but we could do more. So we referenced the health and wellbeing partnerships, and the leader of the council sits on the Chorley and South Ribble ones. There's obviously a direct link in there. But I think there probably is something for me as our local district councillors really having an understanding of our communities and what they want and being out there. We could do more to have a direct link in terms of some things that you're hearing through working with your residents, and it would be good to think about how we could potentially do that and link them into all of our organisations who provide different services. So I think it's just a potential opportunity there for us to build on something to do more of that.
Right. Thank you for that. Sure, Colin, come back.
Loneliness has been mentioned as a problem for creating health. We in Longton, we started a coffee morning which was designed to get people to come and mix together. So perhaps something like that could be done more throughout the borough.
Right, thank you for that comment, Colin. Right, I'll move on to our next question. Councillor Campbell, please.
Thank you, Chair. We are currently reviewing our local plan with Chorley and Preston councils. How are you involved in this, and how do we make sure we embed health services when planning our developments and communities in the future?
I suppose all of us will have something to say on that. So where we are involved in that, between the county council and the local councils, a number of departments are having conversations. I mean, the most commonly known one is the highways. But beyond that, our officers in public health are working, and we've been in this very room advocating for healthy planning policies, particularly walking and cycling paths and hot food takeaways. Again, lifelong homes, working with the developers. So there's a range of things that we're already involved in, and also supporting yourselves with information about population projections and understanding of the demographic changes and so on and so forth. So there is a number of ways we are engaged in your local planning process.
Thank you. I'd just like to bring in Chris, please.
Thank you. So, Councillor Campbell, I think for me there's something around influencing in that space as well. So we talked about educational attainment and the disparity sometimes just within a small geography can be. If we look at autism and autism waiting times, they are unacceptably long, and especially within children, and the impact that has on children going through education, but also the wider family impact that can sometimes have. So there's something around championing as a nationally, we've got the mental health investment standard, which protects ring fences funding for mental health. Nationally, there isn't a learning disability or autism investment standard. So there's something about working with the commissioners, with county councils around that. wider educational attainment piece for me, and that leads into employment later in life and that wider perspective.
Thank you for that. So, Councillor Colton, again, question 5, please.
Sorry. On the prevention side. Oh, sorry. There's an old adage that prevention is better than cure. You know, what are we doing on the prevention side?
Thank you, Councillor Coulson. Just again, from a strategic point of view, there is our Health and Wellbeing Board, which is chaired by Councillor Green, who is, I think, is here, as well as he's a county councillor cabinet member. That board has taken a look at all the information that we've got available about our population, what determines health, where are the opportunities for prevention and early intervention. We had committed to 3 big priorities of the Health and Wellbeing Board priorities. The first one is achieving a best start in life for every child that's born across the county, including South Ribble. So working through the family hubs in people's homes, helping each child develop their best potential, right from when mums are pregnant, families are pregnant, up to, we've got a unifying purpose across the agencies, NHS, education, early years, public health, and that purpose is to get every child ready to learn for school, basically. Every child ready for school by the time they have their 3rd birthday. And there are lots of things that's happening on that front, improving the uptake of 2.5-year-old free early years education, wherever possible, reducing delays in speech and language assessments, right up to toothbrushing, obesity, mental health, perinatal mental health, family issues. So that's one big priority for us on the prevention side. There are a couple more, and they are healthier hearts and happier minds. So we've got 3 priorities: best start in life, healthier hearts and happier minds as the 3 big priority issues that we focus on prevention. And under the healthier hearts, there's again some of the behavioral issues, and particularly tobacco, making tobacco history in Lancashire, having a smoke-free generation in Lancashire, as well as finding risk factors that makes one more prone for heart attack, stroke, kidney disease, heart failure, dementia. That is done through the delivery of NHS health checks program in the communities, often through the GPs, but also in town centres, in community venues. And then the Happier Minds priority mainly focuses on disrupting the addiction to tobacco, to drugs and alcohol, as well as working with colleagues here in the Trust, Mental Health Trust and the GPs, third sector organisations, to reduce risk of suicide, particularly in men, but also in younger people. That's becoming a pattern. So working with colleges, secondary schools, employers. So those are our 3 big ticket items on prevention. Clearly, we are working within a reducing financial envelope over the last decade when it comes to prevention. So we need to be thinking more creatively, more collaterally with other sectors, housing sector, education sector, skills sector, including transport plans to make active travel the default way, making that model shift in how we plan for our transport strategies. So there's a number of things we could do even better on the prevention and early help side of things.
Thank you for that, Doctor. I'd like to bring in Gary, please. He indicated to speak. If any of you want to speak, just through any of the questions, just let me know and I'll bring you in. Thank you, Gary.
Yeah, thank you. Absolutely. Prevention is absolutely the best thing for us to focus on. So in terms of how the organisation that I work for might try and look at that, as SACP has already said, you're getting off to a really good start in life is absolutely essential, and we know from all the research that if that doesn't happen, how that can result in long-lasting health effects throughout somebody's life. So, and obviously we have a big role to play in that in terms of our maternity services. So for us, there'll be a range of things that we do to help people sort of directly, if you like. Then there's the things that we do when people might be in for something else, but we're able to have that conversation with them around alcohol or tobacco, or, you know, as I say, they may be here for a clinic because they've perhaps, you know, broken a leg or whatever, but there are other conversations that we can have with them, and that's a really important role for us to play, because clearly people are in that mode where they're hopefully trying to listen, and we can engage with them. I guess then the other bit that I would mention as well is, as I mentioned at the start, we employ an awful lot of people, and there's something about how we help with the health and well-being of our own staff, and we've got a wide range of things where we try to do that in what is obviously a very kind of challenging and stressful job, but equally there's lots of things that we can do to help people, both with their experience of what it's like in work, but also their experience out of work. And then again, as Sakvi kind of mentioned, there's something about good jobs that are the basis for a kind of healthy and happy life. And again, you know, in terms of career progression, career development, that's another really important way that with that, as I say, nearly around kind of 9,000 people, that we can work with them to hopefully encourage them to live the kind of happiest, healthiest life that they can. And as I say, then that's by far and away the best thing that we can do, whilst obviously also being there for when, you know, people do need help, and you know, we've not been able to do the prevention and people need the cure.
Thank you. I'd like to bring in Laura, please. Thank you.
Thank you. Yeah, so just building on the prevention, which I think we've covered quite a lot. I think there's something as well that we've been discussing together, is how do we make sure our populations know what's available, because I think we've got a lot of services, a lot of new services that have been introduced. And I've talked about community mental health team, the transformation that's brought with it, the investment of really senior clinical practitioners that work in GP surgeries to almost be that sort of safety net of working with the GP to see somebody that may have historically been a referral into a mental health service that they didn't really meet the criteria for. They're able to signpost and say, actually, I can provide some, you know, time limited intervention, or I can signpost them into the right service. So I think one of the challenges is, as we're changing so rapidly and implementing new things, it's making sure the population know what's available. So we've had a conversation as partners talking about winter. What are the messages we need to get out there? We've got, you know, a new mental health IRS service, which is anybody can ring to ask for support with mental health and be assessed, signposted or taken into different services, working again with BCFSE, local authority and other partners. And I think there's something around, we need to get better at that, because I think there's a lot of services out there, not necessarily everybody knows about that. So I think that's part of the prevention as well, how we get that known and spoken about at community level.
Okay. Councillor Colton.
So how do you actually get it down to the people? You'll be talking about really, really, really good stuff. So how do you get it to actually to let people know how, you know, the facilities that are available if you're in some, you're worried about something?
Thank you. And it's one of the challenges that we've got. So we have comms teams, and we have a system comms team that will coordinate campaigns, posters, radio, social media. We have organisational comms teams that will push information out. Ultimately, it's the strength of our relationships working together as well, and knowing what's available. So, you know, just getting around the table, talking about winter, what's on offer, who can offer what. We've already started to realise there's a lot more out there that we realised from a mental health perspective only. So working with the district council, working with, Lifeline and what their offer is, we weren't aware fully of what that offer was. So I think there's something around, there's formal comms, but there's also that we're a community of health and wellbeing professionals that should be championing and talking about the offer and understanding that. So I think that's getting better, but we do need to strengthen that as well, because we need to almost attack it from two angles, from organisational, but also getting that information out to people that are, living in the area.
Thank you, Laura. I'd just like to bring in Sarah, who's indicated to speak. Please, Sarah.
Thank you. It was just to build on that point, really, in terms of some of the conversations, the practical things that we've decided we're going to do over winter, because we've had some great offers from both Chorley and South Ribble Council, District Council, about helping us to get some of those messages out. So we've got a meeting on Wednesday with the communications manager from your organisation, plus Laura's organisation, plus Gary's, to say, actually, what are some of these preventative messages that we want to get out over winter? And you've kindly offered to help push those out on your social media. And that's huge for us, because you've got that reach into your residents that actually sometimes people listen to different people. So that's really vital for us. And then just in terms of some of the activity of the services that we could do in terms of prevention, when we were talking about the winter services, we were talking about helping people stay well and connected. We were talking about some of the things that you do more naturally around kind of affordable warmth, around enabling people to stay well in their properties and their homes. And actually, as organisations, some of the people on this table are working with those residents day in, day out. So it's going to take longer, but it's connecting some of those stuff up in the background, as well as pushing the messages out in the first place to help people kind of know where they can access things, and then some of the public health things as well.
Thank you, Sarah. That's good to hear that you're getting support from the council. My next question is actually to Chris. When Scrutiny, we have another Scrutiny group, when they've met with the Police and Community Safety Partnership, mental health seems to be an area of concern and having a negative impact on partners. What is in place to prevent mental ill health and provide support earlier? And I think this is probably been part of these questions emerging, but thanks, Chris.
Yeah, thank you. So I think there's the relationships are key, aren't they? So relationships with Lancashire Constabulary and the Trust are well. I meet with the Chief Constable around some of our joint concerns, and I suppose nationally there is the right care, right person model that's been rolled out in London, but it's been rolled out up in Lancashire as well. And I think that's going well. I would want people that are in mental distress to be seen by mental health practitioners. I wouldn't particularly, that there's the right person, right role. So for me, there's very much on that preventative. So Laura mentioned around their initial response service. So that's one number for any mental health concern. Alongside that, we've got our street triage service. So that's where there's a mental health practitioner working in that service with a police officer. So that if there's a police officer on the street and they come across somebody that is, or they're called to somebody that's in distress, that they will phone the street triage, and that police officer there with that mental health practitioner will be able to look at mental health records and provide more timely care to look at de-escalating that situation. So that what we've seen from the data since that street triage has been in place is that there's been a reduction in people that have needed to be detained under the Mental Health Act, and a reduction in people going to A&E as a result. So it's early days, but it's absolutely the right model, and we'll see that scaled up right across.
Thank you for that, Chris. Councillor Pritchard, thank you.
Just wanted to know how you work with service users, including carers, to help shape planning and service delivery. We have 5 community hubs across South Ribble that work very closely with the communities. Is there a way that we could use these hubs to support the work? I can see you nodding. Thank you.
Yeah. Thank you, Councillor Pritchard. Yeah, absolutely. So service user and carers form a massive part of our organisation. So we have, as I mentioned about the network, so we've got service user and carer councils at network level. We've also got a trust-wide service user and carer council, and the chair of that council sits on the attends trust board monthly. So to able to give that real insight into what the feedback is coming from service users and carers, and using so within policy development, service transformation, we would have service users. We are huge in the organisation on quality improvements and really embedding that through from practitioner level right the way up to fellowship of quality improvement practitioners. And we've now trained some service users and their carers in quality impact and quality improvement, so that they're working with us as one team to develop and change service for the better. So I'd be really happy to have a further conversation about it. Really important.
Thanks. Just building on what Chris has said, and I think it's so valuable, that engagement, and I think the work that we've done with LTH around Care Connections. The name Care Connections has come from our service users and carers who've been with us every step of the way. They're part of that joint transformation. They attend our meetings. We've got, again, they've been trained, they're supported. And I just think that, when we get together and we're saying, what are we going to call it? So, the NHS will have all their acronyms and we'll think of something to make it an acronym. And they just came and said, why can't we call it Care Connections? Because connecting care services. So that's what we've gone with, because, these are the people that are going to be accessing it, not, it shouldn't be coming from us. So that's how we've come up with those names, but absolutely integral to service transformation. Same with community mental health transformation. We've got a service user and carer representative on all of the task and finish groups, developing that model, what works as well. But there's always more we can do, but absolutely it's part of how we deliver.
Thank you. Councillor Keith Martin.
Thank you, Chair. I seem to have the awkward questions. So, I think firstly, as a committee, like place on record, our thanks to all who helped during the COVID issues that we had, the pandemic. I personally know the work that was done with Lancashire County Council, and I have an idea of how that was done through the rest of you guys. One of the things is probably the question is how did that affect the not hear me? Okay. How did that affect the delivery of health services between you? The other question then would be around staff. You already alluded how you help staff, I suppose. So it's more directed at you, Dr. Saxby, with regard to how you've helped your staff through that and going forward. And obviously there's an increase in waiting lists, which we all see. And I'm trying to link the two questions together. Is that how has the financial impact stop that or help that, or do you have plans to sort of like manage that and try and improve services for us?
Okay, good question. A lot in there. So do let me know if I kind of miss any bits out, and obviously I know other colleagues will want to come in on that. So did it have an impact? Absolutely, in so many ways. One, clearly it meant that for a period at least we had to stop providing a range of services because we weren't able to provide them safely, both for patients and for our staff. Second, clearly we had a number of patients who came in with COVID, and what we had to do effectively, say overnight, but with little notice, was redesign the entire physical layout of our services so we could try to separate emergency services for patients that didn't have COVID or had been tested and found not to have COVID, and those that were suspected to have COVID. And then just the physical way we provided services in terms of PPE, in terms of having to whether it's air changes in rooms. Clearly we've always been used to having areas of the hospital like operating theatres that were very clean, with air that was turned over and filtered. Effectively that kind of turned more or less, not all, but most of the hospital into a kind of a sort of, as I say, a kind of high tech zone. What I would emphasise as well, because clearly that was a really challenging time, both for services and our staff, is what it also brought is an awful lot of partnership across organisations, particularly the sort of provider that we are, sharing equipment, staff moving across organisations, working together in ways that we would never have done before. And also it led to some pretty rapid innovation and change in services, particularly around kind of remote and video services that we, kind of could have done, maybe did a bit of, so I would try and put some sort of positives, if that's not a kind of term. But clearly when it came to our staff, you asked about how we kind of try to support staff through that. Well, obviously trying to get them the right equipment, trying to get the right advice so we knew, that we could minimise the risk to them, trying to support them for our occupational health services, clearly for those staff that then contracted COVID and long COVID, trying to support them, and clearly for those staff that were kind of taken from us, trying to support with their kind of workmates and their kind of family. So, a kind of huge impact in many ways, and I know other colleagues will come in. So just you touched on waiting lists, which again, everyone will probably want to come in on that, but there is obviously quite a specific for us because, as I've said, for quite a period of time, we stopped providing services, and therefore people were requiring operations and other things, and they weren't getting them. And we had some challenges on waiting times going into COVID, but obviously what that did was make it, kind of so much worse. So just to, I could talk for a long time about this, but what we've been doing then since COVID is trying to safely recover services, whilst also providing care, because we've got patients in the hospital right now that have got COVID, so we need to keep an eye on that. But what we've been trying to do is crack on with getting those waiting lists down. There is a long way to go. Our plan for the end of this year is for those routine patients who are on a waiting list to try to get to the point where nobody's waiting over 65 weeks for treatment. We've got that down by over 50% this year, so it's coming down. At the moment, we are on track, notwithstanding, what might happen in winter and, again, COVID or indeed strikes, although, as you might have heard today, hopefully that's moving on, but we shall see. So between now and year, and I'm hoping that we'll get to the point where we don't have people waiting over 65 weeks at the end of the year. Now, clearly, 65 weeks is still way too long, but at one point not that long ago, we were trying to get down to 104 weeks, so 2 years. So that's the sort of scale of which we've kind of improved. What I would say as well, we obviously have tried to do is make sure that whilst we're able to provide services for patients that are waiting for routine surgery, that we also obviously care for emergency and urgents and soons and life and limb threatening. And obviously that's really important too, because we've got to do both. And this year, we're also improving our urgent cancer waiting times, for example. So I think we're managing to make progress on all of them. So it's going in the right direction in summary, but still, too high than I would certainly like. And, I remember, not that long ago in the NHS in my lifetime, because I'm only 28, we got down to 18 weeks. So, that's the sort of scale of which that in an ideal world, I'd like to see it back to. I think you also mentioned kind of financial impact. Well, clearly it did have a massive financial impact at the time in terms of trying to get as many kind of services as possible, spending money on things that we didn't use to spend it on, equipment, making areas clean that weren't clean before in that kind of technical sense. So, clearly where we are now is we are trying to get that backlog down, and that obviously has got a cost to it in terms of services that we're putting on extra clinics, extra lists. So there is a cost, as I say, that cost is one that we now kind of want to meet. We haven't got the cost of having the hospital separating quite the way that we had before, but there is still a cost of COVID, and there are still patients in the hospital right now with it.
Thank you for too long there. It's okay. Thank you for that, Gary. I'd like to bring in Chris, and then I'd like to bring in Dr. Saki, who's also indicated to speak. Thank you.
Thank you. And everything that Gary's talked about there, you could translate into the world of mental health. I think there's just a couple of things I'd pull out is around district nursing teams and the amount of end-of-life care that was required in communities and the impact that had on them as teams and individuals. And we had commissioned a resilience hub within Lancashire and South Cumbria to support colleagues through that really acute phase of COVID. We saw specific areas of service that were really impacted as a result of COVID, namely children's services. So that there was a huge spike in demand for children's mental health services, specifically around eating disorders. So 100% increase in children's eating disorder services. And that required, transformation of service models to be able to keep up with that level of demand, and significant investment that has gone into certain services, specifically around children. So it was just really to factor that wider sense that I think we will see the impact of that for a number of years to come from that cohort.
Yeah, I'll be brief. The most precious resource we have is our staff across the health and care services and across all the public sector, and they were stretched to the max to pick up jobs that they wouldn't have imagined would be doing. So we're always very grateful for the discretionary effort that goes in over and above the hours that people do, certainly in the public sector. And a couple of things to pull out from that is the stress that's residual in staff that we see. Some of them still are getting affected by, and that really is an important feature that's become more and more visible to all the organizations, I'd say. And as a result of that, a number of initiatives have been started in my own organization some of which you'll be familiar with, particularly listening to their experiences and not just over medicalizing and referring them to an occupational health or a medical or clinical service, but actually shaping the work environment to be a lot more a listening environment, a lot more compassionate environment. I think that focus on staff well-being, I would say, has really seen a step change after the pandemic, something that we need to keep our attention on.
Councillor Martin.
I mean, one of the things when we were told all to go home and things like that, we were asked if we wanted to volunteer for stuff. So I volunteered for the COVID tracker, and I'm surprised you didn't mention it because you all guys got involved in that because county council started it, and it was so good that you wanted it as well. So I think you need congratulating on that as an authority, and for you to recognise that that was a good thing that came out of that. So thank you.
Right, thank you for that. We have the next question, question 9 from Colin, please. Thank you.
Ambulances waiting outside A&E, to get seen, but also there's a lot of publicity about bed blocking, where people are occupying beds because they can't be safely discharged into the community. To outline, is there still a problem, and if so, what can be done to alleviate the situation?
Sorry, that is for you, Gary, actually.
Thank you for the question. So it is a problem because it's not in the place that I would like it to be, because I'd like there not to be any delays, because clearly an ambulance that's delayed outside our ED department is not good for the patient that's in the ambulance or the staff, but also it's not good in terms of getting that ambulance back out on the road and getting to somebody else. So what I would say is that our position in Lancashire South Cumbria, well, obviously we have the services across that piece, is better than it is nationally, better than it is in Manchester or in Merseyside, and our position at Lancashire Teaching is improving. So we are getting that down. The way we do and the way that we are doing that are some of the things that we've already picked up that people have mentioned. So Laura's mentioned Care Connection. So, are we able to give people alternatives to coming into ED? Because if our ED is literally full to the gunnels, then literally sometimes it is just physically not possible to get more people in, which is why somebody would wait in an ambulance in that perspective. So can we give alternatives to ED? We've talked about, and I think it was yourself who asked that great question about the importance of prevention. So what we're trying to do about it then is, can we reduce the demand, give alternatives, give help and support in a different way so people don't need to access our ED, or have slightly different people at the front door in our ED in terms of physiotherapists and other people. So again, we can just get people to the right service as quickly as possible, which in some cases is definitely waiting in our ED to see somebody, but in many cases it is not. So if I call it a sort of front end thing, if that's okay. So there's a lot of work that we're doing there, and whilst I would say it is a problem, it is improving, and it is actually one of the areas where we have people asking us what we've done because they'd like to learn the sort of way that we've done it. There's then that bit where while you're in my hospital, there's lots of things that we are going to do for those patients that generally are admitted into beds. Then we've got to get diagnostics done. We've got to get teams talking to each other to decide what treatment you would need. Then we've got to get the treatment done. We've got then theatres that we might send you to. Are we using the theatres well? Are we getting you there as quickly as possible? Are we then clear that we've got you on the right pathway as quickly as possible to then reduce those delays? Because then we move on to that stage of discharge. And if we can't discharge people, if we can't get them diagnosed, can't get them through that pathway, then there's no room for people to come into ED, because it's like a hotel that nobody's kind of checking out from. So then that piece of work then is okay. So we've done all those bits we need to do in the middle section where we've diagnosed you, we've treated you. Now you're ready for discharge, which brings me to your point around bed blocking. So that's an area where, again, we've got work that we've been doing. So you might have heard something around Finney House, where we've started to step into what is a slightly different area that we wouldn't normally provide that service. Obviously, what we also try to do then is sit down with the people that are working with us in community to try to learn what's working well, what's not working well. And Chris emphasised very strongly that service improvement, kind of listening to people, listening to patients, listening to staff. How's the paperwork? How's the process? Is it as good as it could and should be? Can we then make sure that wherever possible, we do our bit on that sort of relay race to get people into the sort of where they should be, and in that way reduce those delays. So that's kind of point I'd make. I presume I'll probably leave it to other people to come in on then that kind of nursing and residential care and how that can be supported, because that obviously is an area that you will know very well is very challenged. So I don't know, Sarah or Zachary or indeed Chris. Okay.
Thank you. So I suppose there's just two things I wanted to pick up just on patients being discharged and some of the delays that we see there. So within mental health in our older adult wards, what we were seeing is patients being transferred into care homes and then staying in care homes rather than getting back to their own home, and something that we were really keen to make sure that people maintain that independence for as long as possible. So with Lancashire County Council came up with a trailblazer model. So this is where mental health teams will provide additional support into care homes to either step up people into care homes, but to step people down from our acute older adult mental health wards with the aim of rehabilitating to get back into their own home. And that's over the last year has proven to be successful. What we're also seeing is a number of people whose private tenancies are ceased whilst they're an inpatient in a mental health ward, and they've become no fixed abode on discharge, and working with the housing teams for that longer term housing offer that we need to find now for a number of our patients. Today there would be circa 20 patients of no fixed abode in mental health wards at the moment. So it is a real acute problem. We're working well with authority colleagues to take forward, but I think that would be replicated up and around the country as well.
Sarah.
Thank you. Yeah, it was just to build on the point that I think things like the kind of the bed blocking issue is something that can only be resolved by the whole system working together. And I think probably the thing we've not talked about as much is adult social care, and we referred to it slightly, but there is also work going on behind the scenes to work with adult social care to understand that when residents are fit and ready to go home, how we can support them at the earliest opportunity to do that. And we talked a little bit about continuous improvement, and there was some work done at Lancs Teaching last year where we had kind of a warm triage, which is basically one referral, somebody rang each other, picked up the phone, rang each other and got patients seen to it and out of hospital quicker. So there's some really procedural things like that we can do to support, but I think it just shows that actually this is some really complex things that we're trying to deal with across the health and care sector. And I think probably the other element of that I think we could do more with on our district council colleagues is where residents are able to go back to their own homes, but they do need to make an adaptations either through disabled facilities grants or other things, how quickly we can get to some of that to support those residents to get back to where they want to be and where they're going to be happiest and healthiest as well.
Okay, thank you. Councillor Martin.
Thank you, Chair. You mentioned I was just about to ask a supplementary question, but I'm going to continue anyway. Obviously, we distribute that fund. We get that fund from somewhere else. Is there any mechanism for you to sort of pre-warn the fund holders or the purse holders to say that this person's coming out and we need to sort of look at an assessment of getting out? Because the way I see it, just in a household budget-y sort of way, is that if you're spending £100 a day because someone sat in the bed because they need £200 spent in their house, why don't you spend it?
I'll come in generally, and then Gary might have some particular points in terms of the procedural element. It's probably just to say that I think the real opportunities around this particular area, and something that as Lancashire Place we've worked with all 12 district council chief executives to talk about how can we do something together as a group of 12, and housing and disabled facilities grants and making that process as clear and streamlined as it can be is one of the areas of real opportunity I think that's come up for us. So we're really keen to do something on that across Lancashire, but I'm parochial. I want to do it here in Chorley, South Ribble, Preston and West Lancs first as well. But I don't know if there's anything on the procedural things that anybody else wants to kind of add in.
Yes, so I guess in simple terms, we would try to identify as quickly as possible what care and treatment someone needs while they're in the hospital, and then what they will need as a package, either a very big complex one or a fairly simple one, and start talking to them and family and friends or whomever as quickly as possible. Sometimes that position can change. People can be on a certain trajectory and then it changes. So it is, I've simplified it there. It is a very complex and for some cases, very difficult to predict, but for others more so. Then what we start to do is start talking to colleagues outside the hospital in terms of that kind of package of care. Where I think you're right to kind of raise a question is, are there instances then where maybe if we viewed all our resources as one, actually it might make sense to spend something here, because actually you are going to end up spending less in the round. It's just at the moment this person's over here drawing on this budget, and I guess that then starts to get us into some real opportunities, I think, in terms of partnership working, and maybe at some point, potentially down the track, you start to think about, well, do you pool that budget then? And then at the end of the day, it doesn't matter where somebody is, you're going to do the most effective, cost-effective thing for them to get to the right place as quickly as possible. So, I think there is some of that, but I think that is a real opportunity in terms of that kind of place-based working, to say, could we do more of that going forward? Can we kind of talk and understand each other's kind of processes? And I think it was Laura who picked up on it earlier on, in terms of just understanding what everyone can do at any point in time is really quite a challenge in terms of that directory of service. Then making the most cost-effective decision for an individual patient across the whole piece. So I think we have a go at that, but I think there is more opportunity there, because there are delays, and if you're a patient wanting to get home, then and obviously I have to say that if you are in hospital longer, then whether it's a risk around or an infection or a fall, then unfortunately something can happen, and then you are ready to go home, but then you're not, and that's a real that is a real tragedy that we need to absolutely sort of stop.
Yeah, thank you. So I just wanted to talk about the wider impact for the patients that are clinically ready for discharge. So whether that be that they're waiting for a housing package, a specialist placement, or domiciliary care, is that within mental health and within Lancashire and South Cumbria specifically, we've got a number of patients that are having to receive their mental health care out of area. So they're often miles away from Lancashire. The south of England would not be unusual, but definitely up in Yorkshire way as well. And whilst that has a real impact on cost, it's significantly huge pressure on our cost budget. The impact on that person's the experience for that loved one's family, and the distance from a visiting perspective is massive. So I think this is something that it's really of concern for the organisation and for the system, and very much is high on their priority to resolve.
Thank you. Okay, Councillor Colton, you have another question about dental services, and I think this question we felt would be for Sarah to answer, but we'll see. Thank you.
My granddaughter lived in Slough, where she was on their GP and dentist, and when she moved up here, she had no problem whatsoever getting onto a GP's list, but with a dentist, oh my goodness, she couldn't even get on a list where she was paying. Now, is that the norm, or what can be done about it? She has got on, but she has to go into Preston to.
Thank you. So, in terms of the question, and absolutely that should not be happening. In terms of the question, is that the norm? I think probably people will have seen in media and other things that access to dentistry up and down the country is an issue at the moment, and there are challenges with people able to get that treatment and get that service and get the help and support that they need. I think if there are specific questions around how difficult it is to access in this part of the patch, or what some of our waiting times are, or things like that, that's probably something I can take away and bring back specifically. Because whilst dentistry is something that falls within our organisation, I'm going to be completely open and transparent and say I don't have any of the details. So I think it's fair to say it is an issue in other places as well, but we can bring back some more details around that specifically for South Ribble at another point.
Thank you for that. We are actually running out of time, committee. So I'd actually like to jump to question 13. Councillor Jackson, we'll see how we get on with your... Okay, thank you. And I think this question we thought might be for Sarah, but we'll see. Thank you. Councillor Jackson.
And I hope you might come back again another time. But my question is there an update on building a new hospital for Central Lancashire, and what are the next steps, please?
I can have a better go at this one than dentistry. So bear with me. So some of you will have heard of the new hospitals programme, which has been a piece of work that has been in the pipeline for our area for quite a number of years, and previous iterations have done quite a lot of social stakeholder engagement and talks to communities and those sorts of things. So in terms of where we're at, and Gary might want to just jump in on this as well, obviously being part of their hospitals, we do now have money for Lancashire and South Cumbria that has been ring-marked to build new hospitals in our area, and that's both for the Central Lancashire area and also Lancaster, because it is now a piece of work that goes across both Lancashire and South Cumbria. And there is an aim of opening new hospitals by 2035. Obviously, that's still 12 years away, so there's a considerable amount of work to do now to look at a number of different things. So some of those will be what's the new, what we would call model of care for that hospital. So what would be provided in that hospital, as opposed to what services that are currently provided on Gary's hospital sites actually would be better placed elsewhere. So some things that, for example, some outpatient clinics, do they really need to be on a hospital site, or would they be better placed out in some of our community facilities? So there's a whole piece of work to do there, both with clinicians and our patients and our residents, about what that model of care will look like. Alongside that, there'll be obviously all the work around the business case, the scaling it up, the size of it, the location of it, and all of those kind of things as well. So kind of, Gary, you might want to add in, but I think the general update is it is a good news story that we know there's money coming into the area. We just need to work out the details of exactly what that looks like and how we get there.
Thank you. Gary, you'd like to add some comments? Thank you.
Yeah, thank you. So largely, as Sarah said, the real positive is that we are in the programme. And obviously there are some places up and down the country that didn't get into that programme. Clearly, equally, you'll know there are some bits of the country in terms of RAC and concrete issues where there is an absolute kind of here and now buildings kind of falling down. So I think in terms of that national team, they are obviously focusing in on some of their areas. We locally are then looking at how, in the time that we've got, we can look at those service models. We can make sure that obviously, given that, as I said earlier, our hospital is kind of the sort of specialist, kind of all our services link into all the services in the other hospitals. So there's a local models of care, kind of, as we've said, how it works in terms of working with GPs and other people, but then there's how it works in terms of cancer and trauma and all those ones. So finalising that clinical model is something that we're on with. Looking at potential sites is another one that we're on with. Looking at how within the envelope that's been put forward for us nationally, which is an awful lot of money, but unfortunately doesn't go that far, how we could then utilise that to get the best possible outcome. And as Sarah said, that there is, some of the original timeframes that they were looking at for the new hospitals programme were quicker. Obviously, that would have been good. Equally, if you remember, what they've had to do is put some things into the programme that weren't in it before. So they're now the priority in terms of some of those concrete issues. So we've now got that bit of time, but we've not got that much time, because actually that timescale, as Sarah outlined, might sound a long way off, but it's not if you're going to build a brand new hospital and spend kind of billions of pounds. So that's the work that we're on with right now, working with people on it, working with that national team, and we'll be looking to take that forward, because as soon as possible, I would like that new hospital to be in place. And obviously, as Sarah said, there's also colleagues up in Morecambe Bay that would like their new hospital too.
Can I just come back?
We're running out of time, but
because Jerry Hawker, when he came to talk at Lancashire County Council, he actually said, when we asked him, you know, when our new hospital will be built, because there've been reports in social media. Well, it was from the Department of Health. It was Steve Barclay at the time. He said that there were 5 hospitals that had been rolled on, and I named them, and there were 5 hospitals onto the 42 list that had been rolled off. Now, 2 of those was our Preston Hospital and Lancaster Infirmary. So 2033, when we pressed him, well, what's our expected date of a completed hospital? And he said 2033 to 2035. So that's 12 years. That's a long time. He also said that he would, there was ring fence money, but when the committee were talking, we agreed that, and he agreed that he would take the question and our discussion back to the Department of Health and Social Care, of which he was going to visit, to give us reassurances that there was that money, because he said he'd received a letter, the contents of which he couldn't divulge. So we go back to the Department of Health and Social Care for reassurances that that money was there and that our hospital was going to be built in 2033, 2035. So have you received a letter from the Department of Health and Social Care that not only gives you reassurances, but says definitely that we're going to get our hospital, or 2 hospitals?
So I'm not sure what letter Jerry's referring to. We have had formal communication that we are in the new hospitals programme.
Could I ask when you had that formal notification, please?
It was over the summer. I'd have to get back to you with that. So from my perspective, we're in. Now, the work that we're doing, as we've said, is that being in is one thing, but there is an awful lot of work to do to get the model of care that we'd have to be the best one available, to get us, because obviously the model of care is the most important thing, but then the building is important. And you know, we've got a budget that we'd be working to get that. So that's what we're working on. So as I say, I'm not really sure which letter Jerry's referring to, but my take on it is that it has been publicly announced that we are in. Therefore, we are working on that. And obviously, as you know, we have a new minister now, but the old minister made a public commitment. Until someone sends me a letter saying that is not the case, I'm working on it as it is. But I could I'll check with Jerry in terms of which letter he's referring to.
Yeah, he said he received it on the 29th of May.
Right.
The Health Secretary, Steve Barclay, on the 28th of May, on social media, said that our hospital had been rolled off, our 2 hospitals have been rolled off. But he said he'd received a letter the following day on the 29th, but he'd go back to the Health and Social Care Department, of which he was going to visit the week after, for reassurances that that's what it was going to be. And also he'd report back to Lancashire County Council in the spring.
Well, I received a set of slides from my finance director today that had been given to him last week by the national team around our part of the so I guess in terms of slides, letters, actions, as I say, May seems a long time ago now and summer seems a long time ago, but we are in the new hospitals programme. Now I'll speak to Jenny, I'll just confirm exactly what that means and get back to you.
Yeah, I was just going to suggest that obviously we're burning up time now, I think we should ask Gary to come back to us with
Just
that.
one more thing. If you'd like to, I'd like to refer you to the video at Lancashire County Council for the Scrutiny Committee on the 12th of July, and you'll hear Jerry talking for clarity. Okay.
Speak soon. Okay, Councillor Jackson, would you like to ask your next question? We've got it down for Dr. Sackthey. The following questions, we've kind of running out of time now. So if you'd like to just cherry pick from the last 2 that you've got, just to ask one of them if you don't mind, because we still need to bring in Leslie, and we are running out of time. Thank you.
Not exactly. It's back to Gary, really. I think it's you. New technology provides great opportunities to improve health care and health of our population. We understand that bots
are part of the new architecture within the NHS, making assessments and decisions on patients. Do you think that this is morally and ethically appropriate?
When you say bots, so we have robots. We have. Do you mean chat? Do you mean AI chatbot? I mean, what sort of bots are you referring to? Sorry.
I'll give you an example. I'll have to personalise it now because my husband is waiting for surgery, and we received a phone call, and it was from health, and they asked him a series of questions, and at the end, and it was obviously a robot, but at the end there was an assessment, and they gave a decision that his condition was more severe and he would need his emergency treatment sooner. So that's what I'm talking about with bots. Do you think it's ethical and do you think it's moral? And how does it really work?
Yeah, so thanks. I just have to say we have got a variety of bots and robots and things going on. We've always communicated with patients on waiting lists because obviously a number of patients do move away or maybe receive care in other places. So we've generally done that through letters, which obviously is pretty effective, but pretty simplistic. So clearly, what these bots give us the ability to do, which an awful lot of hospitals are using, is the ability to interact with a patient, but do it at scale. Because as I've said, unfortunately, due to COVID, we have thousands and thousands of patients on the waiting list. And at any point in time, what we don't want to do is be sending for people that don't need their surgery, or equally have patients on a waiting list whose condition's getting worse. We don't know, maybe they've not discussed it with their GP. So we need a way of trying to communicate in real time with thousands and thousands of patients, bearing in mind that we've only got limited staff and ringing people up is not a very effective way to do it. So I think, is it effective and efficient? Yes, it is. Is it ethical? I think if done in the right way. And what we would have is where patients, in particular, if a patient says that they don't want their treatment anymore and want to be removed, we've got a check and we have a process whereby we bring that back and check it. Where the outcome of it is that a patient's condition has deteriorated, I guess what we then try and do is get them in quicker. I guess obviously when we see them, that the bot didn't do the job we thought it would do, and maybe that patient kind of hasn't deteriorated, then I guess we've got them in a bit quicker, but we didn't need to. But most of the time, it works pretty well. And what we're then able to do, as I say, is communicate with lots of patients on our waiting lists. Now, in an ideal world, I guess it would probably always be better for human beings to be interacting with human beings. But as I've said, we used to do this kind of thing via letter. We now do it through the bot. I think it's given us something within the right framework. I think it can be effective. In an ideal world, we might have taken on lots of extra staff and kind of done it via human interaction, but that clearly isn't affordable and isn't sustainable. And even then, human beings can get things wrong and human beings can interpret things in the wrong way. So there's always a risk even then.
Thanks for that answer. I also asked that answer for my residents, or our residents in the community. It aids their understanding, and maybe it might not be so strange when they receive a phone call from a bot.
Okay, thank you for that. Now, I am going to bring Laura in because she does want to say something, and I'd just like to say to the committee, we're running out of time now, so we'll still ask questions 16, 17 and 19, okay? But we have simply run out of time. So Laura, you'd like to come in, thank you.
I'll be really brief. It was just on the answer about the bots, and I think it's just important to know as well when these are developed, they're developed with clinicians. So similar to when you ring 999 or 111, the human follows an algorithm. So if the patient says this, it would flag it as a red flag and need urgent treatment. The bots are programmed in the same way because I've been involved in the one that you're talking about. So the consultants build it, say this is what would make this urgent, routine. And then the fail safe is the people that flag as either urgent or I don't want treatment anymore. And there's perhaps been previous conversations about that's picked up then by the human administrative team that will then ring and contact. So I think it's really important to know that it's not built by a robot or a person. It's actually consultants, it's medics, it's nurses that actually build the sorts of questions. So we know that it's absolutely signed off by them.
That's slightly more reassuring. Thank you.
Right, thank you for that answer. We appreciate that, Laura. Now we have Leslie with question 16, then it's Lou again with 17, and then it's Leslie again with 19, and that's the final committee questions. Thank you.
Thanks, Chair. So we know the NHS holds an awful lot of data about us, which has the potential to be sold on. And we just wondered what your views might be and how confident you are that our personal data won't be shared in a way that we wouldn't want it to be. Thank you.
It's good to see the eyes going down the corridor, the table on that. So it's a really, really important question, isn't it? So there are a range of mechanisms of where we hold data and our cybersecurity around them. Then there's the whole piece around data confidentiality, making sure that if we are sharing information with other organisations, it's done within the parameters of, and there's a whole legal framework to share information around, and patients need to be aware, and etc. So it is a source of freedom of information requests that I sign off where people have asked that same question, and the answer has always been that that they're not sold on for profit or anything like that. That data would only be used for that patient's interest for their condition, and that they're well binded within legal guidelines within the NHS around cybersecurity.
Thank you for that. Laura, did you want to come in? No, did somebody else?
Well, only just because, I mean, Chris answered that. I mean, any of us could have answered it in general terms. There are rules, regulations. We have code of guardians. In my hospital, we have a lot of research programs where we will be sharing data with research companies and drug trials and other things. I agree with the question. Personal data needs to be treated very carefully. It needs to be respected. Equally, if we're going to do some of that population health and the prevention piece that we talked about earlier, we need to be able to take individual, kind of data and join it up and do some kind of proper planning. So it is a challenge, but equally, we need to stick to the rules, and hopefully that keeps us in the right place.
Right, thank you. Councillor Jackson, question 17, please. Thank you.
We've read with interest the outcome of Lancashire Teaching Hospitals NHS Trust Care Quality Committee assessment, which found that the trust requires improvement, with the caring element found to be good. What is the trust doing to respond to the outcome, and what reassurance can you provide, please?
So I'm just checking I was okay to answer. So fundamentally, we've received that. Clearly, you'll know if you've looked at it. It's a very big, very kind of complex document. What I would say is it does reflect some of the points that you've kind of picked up in your own experiences. What people are telling you, I suspect, is what the CQC have found. There's an awful lot of really good care in the trust. Our staff in particular, again, picking up Sackville's point, are fundamentally our kind of best asset, and I think they do their absolute best to care for people. But our waiting times in our ED can be long. At the time they visited in the summer, our waiting times for elective surgery for planned care were long, and are still too long, even though, as I described earlier on, we've got them down by more than 50% in year. Some of those areas where they identified in our staffing, some of the pressure, some of the gaps that we've got, those are all areas that I think you'd recognise are areas that we need to improve. So whilst I think there were lots of areas of good and there was some outstanding, overall they've given us requires improvement. And that, is a position that lots of trusts are in. I would obviously want us to be, better than that. I would obviously be, and I'd be aiming for us to get to good and outstanding. But what we've got those issues are not kind of new to us in that regard. So we've got plans in place. Again, picking up the earlier conversations we had, fixing, if you like, fixing the waiting times in the ED is about fixing a whole health and social care system that ideally starts with prevention and has people not in ED. Equally, that backlog around COVID, if the CQC had come in a year's time, I'd like to think we'd have got that down and be getting people back within a year. But even then, it's a year. And I think they'd still say to us that's too long. So, we welcome the report. We think there's bits in there that we can be proud of. There's bits in there that we're not proud of. We've got action plans. We already had action plans to do with some of those. Now we've got the final report. We'll be going through checking that our action plans pick up all those areas. There's lots of specifics in there about training staff, about equipment, about buildings. We need to go through all of that. And then, clearly we'll happily come back and give you updates. If you wanted a deep dive into any of the bits in that with maybe a particular service, we'd happily arrange that. It's a document that we, as I said, need to be held to account for, and it'll take us some time to address it. And anything that we can do to give you more information, we'd be very happy to do so.
Right, thank you for that, Gary.
We appreciate it's not a reflection on the nurses, consultants, doctors. We know their dedication and commitment, and I'd just like that to be noted, please.
Right, thank you. The next question is Leslie, question 19, please.
Thanks, Chair. How can scrutiny be a useful tool for you in your important roles, and how could you see that working, and how can we help?
Thank you. I think that's a really good question. And I just reflecting back on some scrutiny committees that I've been on, I think we often, we're all really busy, aren't we? And we're getting on with whatever our jobs are, and we can often make assumptions. I think scrutiny committee for me often brings us right back down to what is really important to our population, to the people. And I think going to LCC scrutiny committee, and I think talking about the community mental health transformation presentation was done based on what we're doing, but the questions that were being asked were a bit like, oh, that's what people want to know. So we kind of reframed how we deliver our updates, not only to our staff, but when we're going out externally. So I think for me, scrutiny is really important, that we're held to account, as Gary's just said, at CQC, but for other things. But also, we need the support in the delivery and getting our messaging across. So I think it's very much a two-way relationship, and I think, it's a really important part of our jobs.
Right, thank you for that. I'd just like to ask one question myself, actually. It's an operational question, really. So I was just chatting to some paramedics at a hospital in Lancashire, and asking them about the job and the role, and if they've got an issue, what would they say to me is the biggest issue? And the issue that they came up with, which was about what they called frequent flyers. So they were saying about people calling 999, and it was the same people that they were going to on a regular basis, and they even knew the names. And they were saying that there is a high proportion of pickups that they make. This was just a general chat to a couple of paramedics, in a hospital, so it's only one area. So they gave me the impression that there is a lot of people still calling 999 and still ending up going to accident emergency when it's not actually necessary. Are you aware of this issue? And if you are, what more measures can you put in place to try to reduce this down? Or is it a pretty difficult situation? Thank you. Laura, thanks.
Thanks. I think unfortunately it is. I think if we speak to our teams, they will name our frequent attenders. I think Chris has already talked around street triage, so working in partnership with the police, trying to tackle some of the behaviours that are driving the I'm ringing 999, because I think I'll get that instant response and I'll get what I need. And linked with our street triage teams, we've got a frequent attenders team. So it's a team of clinicians that are working with our high use patients that are accessing services, to try and understand what that is. What do they need that is driving them to call 999? I think the pandemic hasn't helped. We've talked about long waiting lists. I think there's a frustration, and I think just reflecting back on my own family, trying to get access to services feels really difficult at the minute. So I think there's a number of initiatives that are going on. From a mental health perspective, we've got street triage, frequent attenders. We're also looking at how IRS can tackle some of that. So don't ring 999, ring IRS, have that conversation. What is it that you need right now? And we can try and get people into the more appropriate service. But it is a challenge.
Sure it is. Thank you for that. Okay, right. So that finishes the questions on the committee. I'm now going to just ask, we have Claire Hunter with us tonight. Councillor Claire Hunter is the council's cabinet member for community, leisure and wellbeing, and she has indicated to ask a question. So Councillor Hunter, please. Thank you.
Not so much as, first I apologise, I come straight from my other job, so. Right. I'm not going to ask you any more questions because there have been a lot of questions asked tonight. All I can agree with on this is prevention is better than cure. I think working with your local councillors, I mean, we've proved this. We've brought an OT in-house. We've put the waiting list for Preston and South Ribble down to weeks rather than 20 months as it was. Our social prescribers, our family support fund when we're working with housing to for installations and everything else. Prevention is better than cure. I will be joining the partnership meetings, and I do have a lot of questions about bed blocking and discharging too fast. So, but I'm not going to ask that tonight because we've been here long enough. But yeah, I found it very, very interesting. I think it's really good, the actual policing and the mental health. I do like that, but like I say, I am about prevention rather than cure. So there's been a lot of good work, and I think if we tie that all up together, it should be good. It's just about working together, isn't it? So that's what it comes down to. And any questions, I'll save for the meeting. But thank you very much for coming.
I'd just like to thank Claire Hunter, Councillor Hunter, for her self-awareness here on recognising that we've kind of asked lots of questions to our committees, from our committee and to our special guests. And yeah, you have to have a scope and scale of how long you can keep them here. So I appreciate that. Thank you. I'd like to now ask if there are any questions from councillors not on the committee. If you could please indicate. Thank you. Okay, have we got any questions from members of the public? And there aren't any here, so we will leave it there. So I'd just like to ask our officer, Darren, if there's any recommendations that you'd like to list out specifically. Thank you.
Thank you, Chair. Just some of the themes that you've discussed this evening you might like to consider as recommendations. The committee thanks the senior representatives of the health partners for attending and answering the detailed questions. The committee welcomes the suggestion that the role of councillors providing valuable insight and feedback on health prevention, health services and determinants of health and well-being be explored further. The committee places on record its appreciation to all health, social care and frontline workers for their brilliant and dedicated work during the COVID pandemic. The committee looks forward to further information being provided on the availability of dentistry services in South Ribble. And finally, the committee looks forward to working more closely with health partners in the future. Thank you, Chair.
So with that, again, thank you so much for coming along this evening. It's been our pleasure, and I wish you a safe journey home. Thank you so much. Thank you.
Move on to the next item.
Yeah, we will do. Right, okay. Committee members, we will move on to item 4, which is an update from Councillor Jackson, as she is a representative to the Lancashire County Council Health Scrutiny Committee. Thank you, Councillor Jackson.
Thank you very much, Chair. This is an update on the Lancashire and South Cumbria New Hospitals Programme that appeared at LCC Health and Adult Services Committee in July. In attendance was Jerry Hawker, Senior Officer for Lancashire and South Cumbria New Hospitals Programme, Director of Transformation for the NHS Lancashire and South Cumbria ICB. There was Steve Canty, a medical lead from Lancashire and South Cumbria New Hospitals Programme and consultant orthopaedic surgeon, Divisional Director of Lancashire Teaching Hospitals and NHS Foundation Trust. Also in attendance was Jane Kenny, lead nurse for Lancashire and South Cumbria New Hospitals Programme, University Hospitals Morecambe Bay and the NHS Foundation Trust. Confirmation was sought by the committee following the government statement on 25th of May 2023 of the announcement of over 20 billion ring-fenced for the next phase of the National New Hospitals Programme. The local NHS welcomed the announcement of 2 new hospitals to replace Royal Preston Hospital and Lancaster Royal Infirmary, including improvements to Furness General Hospital. Mr Hawker stated there still had been no decision on where the hospitals were to be sited or on their appearance. However, there was a commitment to build the hospitals using modern methods of construction. The national programme had committed to 100% single rooms to support infection control. The followed comments from the presentations from the committee. The government wanted to take on a national procurement approach to the new hospitals programme, in principle encouraging the large construction companies who were likely to win the tenders to form a consortium with local construction companies. Speciality services needed to be designed, said one of the councillors, by clinicians for delivery for the best outcomes. Whilst elements of care were required to take place in hospitals, there was work taking place to deliver more services in the community. To progress this, there needed to be sustained investment in community services by a community infrastructure group. Questions from the floor? At this point, I would like to encourage those interested to watch the LCC video dated 12th of the 7th, 23. The meeting is entitled as above, and from 25 minutes in to 37, you will see that I asked questions of Mr Hawker, Director of ICB, on the 42 hospitals purported earlier in the meeting to be built. I brought to Mr Hawker's attention that on May the 28th, the Secretary of State for Health, Stephen Barclay, had stated on national media that not only was the country not going to get 42 completely new hospitals, but that due to structural failure and danger experienced by 5 hospitals to be rolled on the purported 42 new hospitals list, which the councillor named, subsequently, 5 hospitals he admitted, when pressured, had been rolled off, 2 of which were named as our own hospitals of Lancashire and South Cumbria and Lancaster Royal Infirmary. Mr Hawker went on to intimate that it was not so, as he had received a governmental letter, the contents of which he couldn't divulge. I asked what date Mr Hawker had received the letter, and he said on the 29th of May, the day after the Health Secretary's statement on national media. I asked them, when might we expect our new hospitals to be built? And Mr Hawker stated and replied, the years 2033 to 2035. I went on to ask about the new methods of construction that I'd read in the presented papers. What are those methods of construction that have been committed to? And importantly, in retrospect, what was the expected lifetime of these new construction fabrics? Mr Hawker stated 40 to 50 years. So this will be the expected life expectancy of a new hospital. So billions and billions of taxpayers' money is to be spent on buildings, knowing that the expected lifetime is only 40 to 50 years. Expenditure then is to be repeated again and again to tax encumber not only our children, but our children's children to the next generation in perpetuity. Mr. Hawker, at the end of my questioning, said he would raise the discussion and the questions at the Department of Health and Social Care, with whom he was due to meet at the beginning of June. He would also seek reassurance about the roll-on, roll-off hospitals. At that point, County Councillor Erica Lewis stated that she and her colleagues had thought the same as I had expressed, and we would look forward to seeing the contents of that letter of the 29th of the 5th that Mr. Hawker mentioned. Members requested round the table that day a letter from the Secretary of State for Health and Social Care confirming a commitment to build 2 new hospitals in Lancashire and South Cumbria, which would be made public and did not contain commercially sensitive information. And on the status of Chorley accident and emergency, Mr. Hawker says the government is committed to it until the new hospitals are built. This report is a summary of the above meeting of the Health and Adult Services Committee held at Lancashire County Council, July 12, 2023.
Okay, thank you, Councillor Jackson, for that. I'm now going to go to item 4B, meetings and trainings attended by Scrutiny Committee members. I'd just like to make some comments on this, as you can see from the agenda, and give a report of what we've done in terms of training and workshops. So we had a scrutiny training with Dr. Steph Snape, which was attended by more or less all the committee members. We had a very successful scrutiny workshop, which was excellent, where we did a lot of brainstorming and coming up with issues between ourselves as a collaborative team, which was brilliant to see. We are planning a scrutiny, well, the scrutiny planning session is tonight. That's what we've had tonight, isn't it?
I've done the additional ones.
Yeah. We've obviously had representatives tonight coming to speak to us, and can I just put on record the excellent work of Darren Cranshaw in securing those people so quickly. They are really senior people, and I think what we had tonight was very successful. There was a lot of people, they've dropped off now, but there was a lot of senior people from the council, elected members watching, so that was brilliant to have that. I'm now going to move on to item 4C, the cost of living. Just one moment, please. Councillor Martin.
I just add that some of us are invited to be able to do suicide mental health training or the suicide first aid training, which is similar in line to the mental health first aid training, which South Ribble have been doing, as well as our council, Penwellan Town Council.
Okay, thank you for that addition. I'm now going to move on to the cost of living task group. Sorry, just 1 second.
I just wanted to add to what you just said, Keith, because we plan future suicide awareness, but with certification this time. So we've got that to look forward to.
Okay, thank you for that, Councillor Jackson. Councillor Hunter, I think you'd like to speak.
Yeah, sorry, I'm going to have to apologise. I am going to have to go. But I found it fascinating tonight. Well done. And it'd be very interesting to move forward with all the questions and etc. But I do have to go, I'm sorry. Okay.
Okay, thank you. I'll now move on to item 4C, the cost of living group. So we have discussed this as a committee, and we do have a meeting in the diary. I believe we're looking at the 14th of December. The majority of the committee members can make that for us to have a discussion about the cost of living currently in South Ribble, and hopefully coming up with a report and some recommendations of that as well. Finally, item 4D, we have the forward plan. Members are asked to review the forward plan and make sure they are happy with it with regards the suggestion from the Corporate Performance and Budget Scrutiny Committee members who'd like to have an additional meeting in March with our housing partners. And I think that's something that we're all really keen to do, because that is a key factor in our communities with regards to certainly health and well-being Okay, so. Right, so I'd like to close the meeting. I'd like to say to the committee members here tonight, thank you very much for your questioning. It was just met the borderline of being measured because we don't want to volley too many questions at our guests tonight. I thought it was very well balanced, and I really appreciate you guys supporting us and undertaking what we wanted to try and achieve in the pre-meeting. So just like to thank the officers here tonight for helping and supporting us.